Here we go. So I know, medical students, y'all have your surgery mini boards coming up. John O has been alerted. So on your Wednesday sessions, he should be kind of going back through kind of an overview of everything that y'all covered for the past year or so, kind of a quick overview for your mini boards. So we're gonna let him hold surgery topics. Let us know if you feel of any specific weak areas that you might have, so that we can tell him where to focus his time if y'all have anything in specific. Otherwise, he's just going to kind of do a general overview for y'all over the next 4 weeks. Okay, and we're going to continue on with some combination of peds, GYN, mental health over the next 4 weeks for us on Tuesdays. Okay. Okay. Peds seizures. This will be, if you see kids in practice, this will be a topic that will come up most often in the case of mom will bring you her kid with some weird spell, and she wants to know if the kid is having a seizure and what needs to be done. So this is a topic you need to have some familiarity with. So the most important thing to learn is how to take a good history when mom is worried about, this is different if you're in the ER and a kid comes in seizing, that's one thing. If you're in the outpatient setting and mom brings her kid in concerned about some episodes that she's been witnessing, that's another. So you do need to know how to handle those situations, how to handle seizures in the ER when the kid won't stop seizing, how to know when to initiate medicines, what kind of workup to do and when to do a workup and when to not do a workup and when to just reassure. So all of these, we'll try and touch on each of these aspects today. Okay. So you haven't seen the kid. You're working, documenting, and your nurse tells you this is in one of your trauma bays. She got a 14-month-old that mom and dad brought in seizing.
What's his temperature?
Okay. So, vitals.
Yeah.
Right, yeah. He's still seizing, and what are his vitals, right? It's kind of your next question. This isn't your physical exam yet. Your nurse tells you when she saw him, he wasn't seizing anymore. Those are his vitals. What are you thinking?
Thinking deeper.
Okay. So you go into the room. What are you going to ask mom?
How long did it last?
Okay. Okay. So describe the seizure activity for me. How long did he seize? And usually they'll say an hour, because these are really exaggerated to parents. I mean, just imagine it's their baby doing something that looks horrible. So what will have been 30 seconds, they'll tell you it was like 45 minutes. Like, they'll give you some very exaggerated response. So a lot of times down the road, as you're counseling parents, it's kind of good to tell them, when this starts, I want you to look at your watch. Because otherwise, if they don't have very concrete data to give you, they're going to give you a very incorrect answer, because it seems like forever that their child is doing this horrible thing. So yeah, how long? What did it look like? What else do you want to know? Okay. So what other associated symptoms might he have had to go along with his fever? How was he doing before he started seizing? What was going on? Was he like lethargic, unarousable? Was he playing? Had he just fallen and hit his head? Like, what was going on? Yeah, like what was going on kind of right before the seizure activity. What else?
Did he hit his head?
So, okay, any history of recent trauma to the head is always important. What else? It's a kid. What do y'all want to know in kids?
Recent illness that they swallowed something.
Okay.
Vaccinations.
Okay. Vaccination history. Okay. Could have been
Delivery.
exposure, ingestion exposure. What?
Delivery.
Okay, birth history, developmental history. A febrile seizure in a baby who was born at 26 weeks in the NICU for 4 weeks, seizures, intubated. That is a different kid, even when it comes to a febrile seizure, than a kid who was born at 39 weeks and went home in 3 days and has been developmentally and neurologically normal ever since. Two completely different scenarios. You know, we preach generally that febrile seizures usually are not anything to worry about. We'll get to that in a second. Not true in this first scenario over here. If you've got a neurologically impaired kid who's having febrile seizures, there is more to do than if you have this well kid over here who has a febrile seizure. Birth history. And sometimes a lot of these kids have an amazing capacity to catch up. So you'll have some 29-weekers who you won't necessarily be able to tell by the time they're 2 that they were a 29-weeker with a lot of complex birth stuff that happened. Some of course you can tell. Some you can't. So you have to ask. You have to ask mom. Delivery history. When did she deliver? Even if she can't tell you everything that happened in NICU, she will be able to tell you, my baby went home with me, or no, I had to leave my baby in the hospital right after I delivered him because he was really sick and in the NICU for 3 weeks and I couldn't take him home with me. Like she will be able to express something like that to you. So birth history, vaccination history, yes, very important. Have they been seeing the doctor? Have they been getting their well child checks? Have they been getting their vaccines, or has my mom been refusing them? Have they not seen the doctor since they went home from the hospital after delivery? Like you need some kind of history of if they're being checked regularly by a doctor for their developmental milestones, well child checks, vaccinations, or not. What else?
Can I just ask a weird question?
Yes.
What age do you stop asking birth history?
So you look at somebody and you say, this is no longer a kid.
Yeah, if I say the pediatricians will say until they no longer are allowed to see a pediatrician anymore, which is 18.
But they changed that to 21 because they were.
Well, that's insurance, but not really what the pediatricians are comfortable with.
24 actually.
But yeah, so there are 14-year-olds that look like they're 21. So there's some physiology, that may not be so true anymore. But it really is until they're considered an adult. Don't forget to ask about family history, seizure events, and if he seized before. Febrile seizures. Of course, all of this is going to be key. A kid who was fine and went to bed, and mom and dad found seizing, but had been playing and acting normally, is one thing. Versus a kid who you're getting a history of has been ill. Is different if they're having a febrile seizure. Febrile seizure. You need to be able to make the distinction between a true febrile seizure and a kid who has meningitis and is seizing from infection. So make sure you ask enough in your algorithm of questions to make sure you can make that distinction of this is a true febrile seizure versus this is a kid who is ill and is seizing from infection. Okay, so what's your diagnosis? Mom says, no, my kid was born at 40 weeks. We went home together. He has been fine. I've been seeing my doctor. He's been getting his vaccinations. He's developed. So normally, we played outside today. He was great. He ate normally. I noticed when I put him to bed, he was hot, but I didn't really worry about it because this is my 6th kid, and I know there's nothing to worry about with fevers, and so I just put him to bed and figured he'd be fine. And then I came to check on him because I heard a sound he was seizing. So what's your diagnosis?
Febrile
Febrile. These are extremely common. You will encounter these. So the important part comes in knowing how to handle these with the parents who are going to be scared to death, and knowing how to counsel them about febrile seizures, because they're going to have a million and one questions about, does this mean my kid's going to have seizures for the rest of their life? Are they going to have to be on medicine? Does he have epilepsy? Like, they're going to have a million questions about what this means for the, like, long-term health of their kid. So you need to be able to answer their questions. And there are a select few kids who, you know, normally febrile seizures, we reassure and we send home. Like, there are going to be a select few kids who will need more of an evaluation when they have a febrile seizure. So you need to be able to identify those kids and not miss them. Okay. This one isn't quite as dramatic as some of them are. But imagine a new parent who, like, walks into a room and finds their 14-month-old. These are parents who parents who obviously have had febrile seizures happen before. 14-month-old who is shaking all over and not responsive to them. He's coming out of his, so his ain't quite as, but notice he's a little bit hypertonic and twitching. So, especially on the first time around, parents are completely and utterly freaked out. So, you need to, of course, be reassuring and nice to them, but also know what to do. So, okay, a little bit about febrile seizures. They usually start around 6 months of age. Most kids outgrow by the time they're 2 to 3. They're allowed to go on until they're about 5 or 6 years of age. But most kids are done with them by the time they're about 2 or 3 years old. Once they've had one important thing to tell mom and dad is once they've had one, their risk of having another is greatly increased. So the most likely they will have another one. But the good thing with febrile seizures is that in normal kids, which is the reason you need to know about birth history, in normal kids who have no previous known seizure disorder or neurologic impairment, these kids are really not at any increased risk of developing a seizure disorder once they have outgrown their febrile seizures. So this does not put them at any kind of increased risk of neurologic impairment, seizure, ongoing seizures once they outgrow their febrile seizures. What about treating these kids? So they're going to say, oh, so his seizure was because of his fever. I'm going to give my kid around-the-clock Tylenol for the rest of his life to prevent him from getting another one of these because it was so horrible. So they will, ask you about, using Tylenol and how to, what to do with antipyretics. Because, they'll want to do anything they can to keep this from happening again. The issue is that while we know the seizure activity is related to the fever, it doesn't, we don't really understand how they're linked together. So if they happen to get lucky and catch the fever at the beginning and give them something, they're really they're not going to help prevent the seizure. So Tylenol giving antipyretics really does nothing to reduce the chance of the seizure recurring, because we don't quite understand what happens with the fever to make them seize. So, and oftentimes these kids have viral infections and are acting fine anyway, so they don't know about the fever until they seize anyway. And they touch them and realize that they're burning up. But there's really nothing that they can do related to giving Tylenol to help prevent them from getting another febrile seizure. So they do not, what you want to do is reassure and try to prevent them from kind of overusing ibuprofen, Tylenol to keep this from happening, because they really can't do that. There have been studies that have shown that treating these kids with antiepileptics does prevent recurrent febrile seizures, but because of the risk that comes along with having a young kid taking anti-epileptics, we often don't treat them, knowing that this is a self-limited condition that's not going to cause any kind of impairment for the kid down the road. But we're making them assume the risk of an anti-epileptic, which isn't minimal. So because of that, we don't treat, because this is going to go away on its own with no problem to the kid anyway. After you've talked through all of this with the parent, the next thing to do is try to coach them on like what do they need to do the next time this happens, because you need to prep them that most likely it will happen again. What does their course of action need to be? Do they need to rush them to the ER every time this happens? So oftentimes, talking them through how to position the kid on the floor. There's still all kinds of myths about like putting a spoon in their mouth to try and keep them from biting their tongue. Trying to make sure that they know what not to do so that they don't actually inflict harm on their child. Trying to do good. So you're making sure that they know to like lay them safely on the floor on their side, remove all the furniture from around them. I tell them to look at their watch and time it. And if at 5 minutes he's still seizing, at that point they need to call 911. Otherwise, if they know the kid has a fever and the seizure ends within that 5-minute time frame and he recovers normally, there's no reason for them to see the doctor. The reason for them to call the ambulance would be at 5 minutes he's still seizing, or after the seizure he isn't returning to a normal state of consciousness. Alright. Do you need to work up febrile seizures? What do y'all think? Who would need to be evaluated further? Are there markers? Do y'all have markers?
I can get you one.
It's locked.
I can get you one from the office. Wait, what kind of marker do you want? Yeah.
Permanent.
Is there?
Are there any in here?
I'll get you one. Just keep going.
Thank
The
you.
beanbag was a bad idea.
Exactly. Who needs to be evaluated?
Is febrile seizures not kind of like a clinical diagnosis of exclusion?
Nope.
No?
Nope.
Which means like what I'm saying is somebody came in and they had a seizure and they were out and they were hot, but oh, by the way, they can't turn their neck to the left or right. I'm not necessarily going to go down the route of febrile seizure.
Right, yeah. So again, that was kind of back to what I was talking, and this is an easier distinction to make, of course, with adults who can verbalize their symptoms to you. That was back to when you're trying to take the history from mom or the kid, if they're not seizing anymore and are verbal, is trying to figure out the symptoms surrounding the fever.
Sure.
So that becomes actually, along with if you make the diagnosis of febrile seizure, along with reassuring the parent about the diagnosis, really the main thing that you're doing is trying to figure out what caused the fever to begin with. Because you're right, viral infection, ear infection, strep throat, whatever, febrile seizure, if like the kid has been flat out ill, unvaccinated, whatever, like that's different. That's not a febrile seizure.
Gotcha.
That's potentially a seizure related to.
So you're saying once I have the
meningitis.
diagnosis, do I need to like run through an MRI?
Right. So if you're comfortable that, mom gives you the history, no, he was great, he was
Right.
fine, he was playing, like, his sister did have strep recently, but, like, he's been fine, like, he was tearing the house apart, and, like, I laid him down for a nap, and all of a sudden, he started seizing. And, like, you're not really worried with that kind of clinical history that this kid's got,
Not before the age of 5.
meningitis. So, are there any kids, if it's a febrile seizure, are we done, period?
If
In
it
the
lasts
story.
longer than your 5 to 6 minutes, if it's lasts
Okay,
past
close.
the age of 5, if it
You're close. So there are a few cases where you might want to consider doing a little bit more evaluation. Okay, and it comes down to your history about the seizure event and getting mom and dad to be able to give you a good history, which is not always the easiest thing to do because they're completely freaked out. But it comes down to simple versus complex. So, simple febrile seizures, most common kind, less than 15 minutes. 5 minutes, I say 5 minutes because like if we get to 15 minutes and then they call and now we gotta wait on the ambulance and then we're in all kinds of mess potentially. So, less than 15 minutes, generalized seizure, and only one event, 24 hours, and it's a normal kid. Okay? These are going to be the most of them. If mom can give you a good history, if she's able to give you a good history about the time frame and about it being a generalized tonic-clonic seizure, only one for that day, and he was a normal kid with a normal birth history, normal developmental history, you're done. Your main job is to determine the source of the fever and if it needs treatment, and to educate and reassure mom and dad, and that's not a small task.
Of the 30 or 40%.
Because they're going to want you to like admit, consult neurosurgery, every specialist in the world, because their kid just did something terrible. Yes, go ahead.
Of the 30 to 40% that are not necessarily poor history takers, but like it happened somewhere and some other person told me that my kid had this seizure.
Right.
Does that
What do you do
automatically
then?
drop into the complex well?
Not necessarily. So then it just becomes a little bit more difficult of a decision for you to make. So now we're talking about complex. So this is the time when you consider further workup. You don't necessarily do it. You just need to think about it. So this is more than 15 minutes, which again, their parents are going to tell you is an hour anyway. Focal. So actually, you would think that this generalized tonic-clonic movement would be the worst thing ever. It's actually not. This is the reassuring type of seizure that you can get. If you get a seizure that had a focal onset, that usually means that there is a focus somewhere in the brain that's not acting right. So those are the kids that you need to be a little bit more concerned about versus just something happens in fever with some kids and just sets off this this pattern in the brain that we don't quite understand, but we're much more reassured if it's a generalized seizure than if it has a focal onset. If mom can give you a clear history that you're confident in, that like, no, he was fine and talking to me and his arm was shaking and he couldn't stop it, and then he started seizing, that's much more worrisome. Several events throughout the day. So if he has more than one in the course of a day, and then if you have a neurologically impaired kid already. In these kids, with a febrile seizure, again, making sure that you're not dealing with an infection, but like a meningitis type thing. Febrile seizure in these kids, you want to consider if you need to do further evaluation. So what would further evaluation be? Mom tells you you had a focal onset and it lasted 45 minutes, and you believe her. What else? But he has a fever. What?
Children.
What evaluation? You're in like Wyoming and there's not another doctor for like 6 hours. Sorry. What are you gonna do?
Lab.
Mhm. What kind of labs?
CBC.
What are you looking for?
Elevated white blood cells or like decreased glucose. CBC won't give you glucose, but
Okay, so elevated white blood cells. So if you still have some thought in your mind, okay, if I'm missing a bad infection, but one thing to keep in mind is that seizures cause this generalized stress response in the body
yeah,
that's going to potentially elevate their white count anyway. So a metabolic panel would be good because definitely a decreased glucose. And the other, in little ones, remember any type of electrolyte imbalance, especially calcium. So if the kid hasn't been in care much, then like potentially you have some kind of like DeGeorge syndrome or something that hasn't been diagnosed yet. So you can do in these kids, again, it would be rare for it to be associated with fever and not a non-febrile seizure, but considering lab work, if appropriate, based on your exam and your clinical suspicion and how much they've been seeing a doctor and everything, is potentially okay. The other thing that everybody wants to talk about, though, is every mom wants you to image her kid's brain to make sure he doesn't have cancer that's causing his seizure. So when do these kids need imaging and or an EEG? Do they ever?
Well, if I'm in Wyoming, I doubt I have an MRI.
You do. You have everything you need. The answer is almost always this isn't necessary, especially the EEG. In febrile seizures, there's really not an indication to get an EEG. If you have this kid, though, especially here, especially if it's a focal onset, then you'll want to consider imaging their brain. Okay, of course, MRI is the best test that you can get as far as imaging is concerned. If you have any concern about there being a bleed, if they can give you any kind of recent history of a fall, if you have any concern about a bleed, go ahead and get your CT. If you can't get an MRI for a while, you can go ahead and get a CT, but MRI is going to be your best test. But for sure, think about imaging if mom gives you some kind of focal onset to the seizure, or if you just have this complex febrile seizure that you're uncomfortable with, you can consider imaging. There's really never an indication for an EEG in a febrile seizure, though. And most of the time, they don't need anything except reassurance and education. Okay. Okay. Hold up. He's actually, all of that didn't happen. You actually went into the exam room and he's still seizing, and it's been 20 minutes. What are you going to do now, doctor?
Go yell at the nurse.
Okay? So what are you dealing with? 20 minutes out, he's still seizing. What are you dealing with? So status epilepticus. It doesn't happen often in febrile seizures, but it can happen. And in this case, whereas febrile seizures really are a completely different category from non-febrile seizures when you're dealing with them diagnostically and kind of managing them chronically, in the ER setting, if this kid comes in status, you deal with them the same. So what do you give to stop him from seizing? Because remember, seizure activity in the brain for a smaller duration of time is fine. Like, as horrible as it is to look at, it doesn't do them any neurologic damage. But what can happen over an extended period of time, usually after 15 minutes, they start to get hypoxic injury from the continued seizure activity. So there can be some damage that occurs after the 15 minutes. So this is usually when we start from the textbook administering medicine, even though I think in real life it happens well before this point. So, but what would you give? What do you want to do? Okay, so Valium Ativan, right? How do you dose it?
0.1 or 0.2 mg per kg.
Yeah, so there's, and actually there's a little, what are those things called? Yeah, that help too. Instead of trying to figure out what his weight is when he's seizing, and like there are these tapes where you can.
We don't have those. It's in the crash cart.
You basically lay it out and see how long the kid is, and they're able to kind of estimate his weight based on his length and give you the amount to administer. So you can pull out one of those tapes, because he's not an adult, it does have to kind of be weight based. The tape will give you a better idea of how much to give. What if you can't get a line? The nurse is like, he's seizing, I can't get access.
It's your osmosis. Diastat.
So each of these Valium, diazepam, and Versed, and midazolam, have, Versed has a sublingual version, and Valium has a rectal, which is the Diastat, a rectal version, and you can give it IM too. So there are some of these medicines that if you can't get IV access, then you can administer in other forms.
I was at just maybe a funny story, which I'll make real quick. But when I was in residency, you know, I was doing some modeling immediately when I got out, did some locums work. I do ERs and stuff like that. But also when I did want to get stressed out, I would like go to an urgent care, right, and just wipe everybody's noses and do. But one time I came in and kid came into an urgent care in status that had been seizing for over 15 minutes, and they came in. This was an urgent care, you know. So they actually did get IV access. They were actually able to do that, which I was impressed with. But if we didn't, I wasn't sweating at the time. Although looking back, I was sweating a little bit more because I was like, "We'll just get rectal diazepam." And I told that to one of the nurses, and they were like, "Yeah." They were like, "That's like $400 a day."
It's super expensive.
They're like, we don't have that crap here. So you're probably not gonna have, you know, your rectal diazepam or something and stuff. But
So
maybe
what do
if
you
you're
do?
lucky, you do. I mean, you give it IM, but it's just you wish, you know, they wouldn't take longer. You know, you wish it wouldn't take 5 minutes or however long it's gonna take to start getting
Yeah, it just doesn't act quite as long.
Yeah.
So you're already in status, so you're already acting, and now we just gave a medicine that's going to take another several minutes before it's going to work. It's not having.
You totally answered the question that was going through my head is why don't I always do it?
So after that, I mean, even febrile seizure in the hospital, again, IV is probably unnecessary.
It's hard to get an IV access once they're seizing and won't stop. Okay, so we already talked about all of this, really. So, you know, the seizure stops, and mom's like, "What you gonna do?" Like, "I'm gonna send you home." You're like, "What?" You know, so you have to know how to like. Usually not. You're not necessarily gonna do that if the kid was in status, but like if they come in seizing, and like it's gonna take you like sitting down for about 30 minutes and being able to invest a little bit of time with mom and dad to be able to explain why you, the very uncaring and mean doctor, are about to send home their 15-month-old kid who was just seizing and not like keep them and do some multi-million-dollar workup about why it happened. So, you know, just be comfortable with being able to explain to them kind of the epidemiology of febrile seizures. They can expect for it to happen again, that it's not going to hurt them, that they're going to outgrow this, that this is not going to cause any kind of any badness to them, they're not going to more likely have seizures, all that kind of stuff we already talked about. And when to come back to the doctor for them. And make sure you're comfortable with why they have a fever. Okay? Okay. And the AAP has some recommendations. I know you can't read this, I'm going to tell you what it says.
Put numbers next to
Has some recommendations related to febrile seizures. It's basically what we just talked about. The only other thing to remember is in kids 6 to 12 months of age. If they are 6 to 12 months of age and have not been properly vaccinated, consider doing a lumbar puncture. It's the same concept of a kid who is febrile, period, in infancy. But kids don't always show us that they're sick. So if you have an unvaccinated or a partially vaccinated kid who presents with a febrile seizure in their 6 to 12 months old, consider doing a lumbar puncture. Let the thought cross through your mind at least and decide if it's necessary. Okay?
We're not talking all
But
vaccines.
are we dealing in this situation the same like with meningitis that like, you know, time is everything?
Right.
And
So this would be like, you're correct. So this would be like a 6-month-old coming in, has a fever, was seizing. When you're dealing with febrile workups, by the time they get to 3 months of age, the algorithm changes because at that point they're no longer a newborn and there really can be clinical signs that they are ill to the point where they need to be hospitalized, they need a lumbar puncture, they need all of that workup done. So you should be able to get some clinical history from mom that would push you towards this kid may be sicker than what we think and I need to do a lumbar puncture. When I think you should have this thought cross your mind is if you're dealing with someone who hasn't been the caregiver of the kid. Unfortunately, we've all seen this of like someone brings the kid into the doctor who like just picked the kid up and has no idea what's going on clinically. You know, like they don't know. Or you know you're dealing with like a caregiver who you can't trust. Like you don't, if at that point in that situation with a 6-month-old, you would want to err on the side of go ahead and doing the lumbar puncture. If you're dealing with like a concerned mom and dad who's giving you a really good clinical history about how well the kid has been doing, this isn't a recommendation from the AAP to do lumbar punctures on all 6-month-olds with febrile seizures. You just need to be able to have, like, this needs to come up in your mind as like, do I need to do it? And you need to go ahead and bite the bullet and do it if any of those situations exist. They can't give you a history. They don't know this kid. They're an unreliable parent who hasn't been taking their kid to the doctor anyway they haven't been seeing a doctor. They're behind on their vaccines. They haven't been going for their well child checks. Like, this is not a on top of it parent. So you may not necessarily want to trust their clinical assessment of how well their kid has been in the past 24 hours anyway. So in those circumstances, you may want to go ahead and do it as part of your workup of their seizure and keep this kid while you're kind of getting your initial stuff back.
So under 6 months though?
Under 6 months is completely different. Under 6 months, where there is no such thing as a febrile seizure under 6 months. So
Okay.
under 6 months, if they seize with a fever, like we're talking about, they're
You said
sick.
6 to 12.
Yeah, they're sick until proven otherwise under 6 months of old, because it really isn't a clinical entity until they get to 6 months of age. So, okay, any other questions related to that? Okay, moving on to the other category. It's a little bit more hard to deal with. Now I don't have an eraser.
I don't got one of them.
There's
Is there a napkin or something? Yes.
That's good. Another quick question.
Yes.
So if there is no documented temperature, documented fever,
Mhm.
and the parents are only able to bring the baby in, let's say 2 hours afterwards, and they say he was warm, I think he had a fever, but or perhaps they gave a Tylenol.
Mhm.
So
Thank you.
then would you do a full workup, and then does the febrile seizure become the diagnosis of exclusion?
Yeah, so in those circumstances, if mom and dad didn't check the temperature, then you may have the clinical suspicion that it was a febrile seizure, they've been sick. Then you can still kind of do that education of what you clinically think the kid had. But yes, you're right. At that point, you're kind of forced into the non-febrile seizure route because you don't want to miss something. So they're forcing your hand down the non-febrile path, but you can kind of split the difference. If you need to do a little bit of a workup because you don't know for sure that they did have a documented fever, go for it. But you can still kind of do the education of like, I really think this is what your kid had, and I think this is what's going to happen. I think you'll notice that he may have some more of these, probably only ever related to fever, and he'll outgrow it by the time he's 5. But because, we still need to do all of this workup, so. Okay, so you got another kid. This time he does not have a fever. Oh yeah, that's because I have a meeting. Sorry about that. There you go. So what do you think? He's not having a febrile seizure, right? Unless, like you said, mom just gave Tylenol or something. Okay, non-febrile seizures, a little bit different in kids. Take a little bit more evaluation. And they come in all shapes and sizes.
I'll be honest with you.
Do it.
I said that kid might be going to children's neuro.
So notice, both sides involved. Both sides involved. He's twitching all over. Mom is talking to him and rubbing his head. He is not trying to get to mom. Like, he's not responding to her at this point. You know, all the good questions we get to ask adults, did you lose control of your bowel and bladder and all that kind of stuff, doesn't really help because they all still TT in their diaper. So you can't really know. So you have to look for other, you know. Most kids this age, though, are going to be reacting to their mom stroking their head. You know, so mom should still be able to tell you that, like, he didn't talk to me throughout that episode. He wasn't reaching for me. He didn't grab my hands. You know, he wasn't trying to get in my lap. Like, he wasn't doing anything to me. So this would be kind of generalized tonic-clonic activity. Another one. Imagine how terrifying this is, right? You're not medical. Like, you're a mama or a daddy, and you're not medical, and you see your 6-month-old drooling. Like, this is terrifying to parents.
It does look like a cabbage patch. Those are scary.
Most of these that I found, these are like parents where the kid already has a diagnosis and they're like chronicling their, you know, life with a kid with seizures, trying to help educate this is what it can look like kind of thing. So, but it's so like terrifying to parents, right? And that's a really cute baby too.
It's almost like yours, Dr.
So again, notice, like before, she's coming out of it now, but it was bilateral, shaking motions. Her eyes were deviated. She was drooling. Because, you know, your parent's not necessarily going to be able to tell you generalized tonic-clonic activity, so you need to be able to prompt them for, like, were both arms and legs involved? Was it just one? You know, were they looking at you? Were they whimpering? You know, because in generalized activity, none of that's going to be going on. They're not going to be aware. Okay, different type. So notice how unimpressive this is. So mom tells you she's like picking at her shirt. You're like, okay. She is having a seizure.
Would you call this focal?
Nope.
No.
I mean, it's just one arm.
We'll talk about that in a second. She's still seething. Just so you know. She'll come out of it here in just a second, and then she'll go right back in. This is just to make you aware that, like, all seizure activity isn't going to be extremely impressive to parents. So if parents are coming to you trying to explain these weird recurrent episodes that their kid is still having, you need to take a little bit of time and ask some questions, because some of the seizure activity is not very impressive at all. Okay. Wait, she's about to come out of it for just a second. Watch, she like all of a sudden becomes a little bit aware. Oh, there she is. Put your hand down. There she is. She's looking at you now. And here we go again. Now she's seeing. She deviates her eyes. She doesn't notice anybody now. See her turning her head. If you called her name right now, she would not answer you. Okay?
Dodge the bullet.
Okay, what do you notice? Look at how nice and flexed that little 9-month-old boy is on this side. This is how he's supposed to look on this side. Over here, this is how he's supposed to look. This is not how he's supposed to look. But, look, good eye contact. He's grabbing.
I would be freaking out.
So he's aware, like this baby is aware and looking around, but he is not in control of this extremity at this point in time. Okay, so there we are. Yeah, mom's trying to figure out what's going on. She has no idea. I think they're describing the activity to one another, trying to figure out. Maybe one of the most difficult types to figure out. Mom's calling her name. I don't know if y'all can hear. Mom's calling her name. And she's not reacting to her. But she's standing. She's playing with a crayon, kind of.
Can you look at mommy?
And here we are.
You okay?
Ooh.
You okay? You wanna lie down?
Yeah. She's still exhausted. And so she comes out from behind her little easel with no pants on.
Those absence.
And watch. So that was a more impressive one. That one lasted a few seconds. Watch this one. Watch how difficult this is to pick up on. Oh, hold on.
Struggle
That's
through.
dangerous. Fall down.
Watch that. Watch this one. So she's playing. Playing. Oh.
Haley, what's up? Haley, what's up?
And that's it. Like, notice how.
Haley.
That is it. Mom she already has diagnosed, so mom, like, is attuned. But, like, I mean, what kid doesn't just, like, stop and stare out into space for a second, right? So,
You need to be paranoid.
yeah, I gotta go.
Everybody has seizures.
Puppy.
You need to bring
Oh my
all
God,
three of
my
your children in.
She never listens to me.
So, okay, here we are. This, when you're dealing with non-febrile seizures, the most important part is your history. You gotta determine if it's generalized or if it's partial. Okay, tonic-clonic activity is easy. Almost. So generalized seizures means both hemispheres of the brain are affected, right? So when they're having generalized seizure activity, whether it's a 10-minute tonic-clonic seizure or something much shorter, both hemispheres of the brain are affected. They will lose consciousness. They will not be able to respond to you. They can't talk back, because both sides of their brain are involved in this very unorganized neurologic event that's happening, okay? So it helps you know that someone is not telling the truth if, they're shaking both arms, and they're sitting in their wheelchair and shaking both legs, and you're like, hey, and they can talk to you. It's not possible, okay? You can't.
And you will again.
You can't have bilateral activity and then being able to verbalize to you. It's not physiologically possible, and yet we see it all the time. So when that happens, think they're more likely crazy than they are having seizures. The other thing that to remember with generalized seizures is it can be secondary. So when someone gives you tonic-clonic activity, as a history of tonic-clonic activity, what you then need to do is ask them enough questions to make sure that you're comfortable that that's how it started. And it didn't start focal and then generalize, okay? Because that can happen. So you need to press mom with, when the kid started seizing, what did it look like? Did he start like this? Or did he start with a twitch in one hand that then turned into activity on both sides? Because secondarily generalized seizures are a different thing than seizures that start generalized. Okay? So you have to be able to know the difference between them. Mom may not always can give you a good history. Videotaping it is great when the event happens for you to be able to witness it yourself and see what's going on. But remember this. Remember the other types? Atonic seizures, myoclonic seizures. There are kids who will just all of a sudden lose tone. They'll just drop. Their head will just drop. Or they will just all of a sudden like throw something, like they just have these myoclonic jerks. Both of these are harder to know because they're so fast that you don't really have the chance to realize that they can't respond to you in the middle of the episode because it happens so quickly. But all of these are generalized type seizures, okay? Partial. You have simple, you have complex. This is all related to their level of consciousness during the episode. The little baby who was looking at mom, but his one arm was seizing, simple partial, okay? He was aware, looking at mom, he grasped her hand with the other hand. He had no impairment in his level of consciousness. That's a simple partial seizure, okay? The little girl who was picking at her shirt, it was not generalized. She was not having generalized activity. She was picking at her shirt. It was a partial seizure, but she was not aware. If you had called her name, she would not have responded to you. When their level of consciousness is impaired, it becomes complex. These are really complex partial seizures are really difficult to pick up on because it doesn't involve bilateral hemispheres. Their symptom all has to do with the part of the brain that's affected. It all has to do with the focus, where the focus of their seizure activity is coming from. So if it's coming from their occipital lobe, all they're going to have are visual symptoms. If it's coming from like the olfactory part of their brain, all they're going to have are these like smell sensations. So these are like extremely difficult to like pick up on and know because some people will only have paresthesias. They will only have visual signs and symptoms. They'll only have smells. And even when it gets at its worst, it will just be this like picking sensation or like smacking or something like that. So in these circumstances, if mom or dad are concerned about some atypical pattern of behavior or mannerism that the kid is doing over and over again, it's worth your time to sit down and try and get a good history because complex partial seizures are extremely difficult to get a good diagnosis of. And these kids do much worse. They usually have a much worse outcome than the tonic-clonic seizure kids do. These kids are usually much sicker and they're much harder to diagnose. So it's worth your time to sit down and try and figure out what's going on with these little weird spells that happen. Okay, and remember, these simple partial and complex partial can secondarily generalize, okay? But you need to get a good history of how the seizure started, okay? Okay. When you're trying to work this up as an outpatient setting, history is everything. History is everything when you're dealing with seizures. It's going to help you figure out who needs further evaluation, who needs medication, who needs referral, who needs imaging. So you have to take your time to take a good history, all the way from birth history all the way up to, are they having one type of seizure? Are they having several different types of events that could potentially be seizures? So history is everything. In non-febrile seizures, we image these kids a ton more than we do febrile seizures, okay? Any kid who has what you think could be focal onset to their seizure, they need an MRI of their brain. If you think they have focal onset, they need an MRI of their brain. If they don't recover to normal mental, so everybody's gonna have a little postictal period, but if they don't recover to their normal baseline mental status in a timely manner, if they stay altered for a prolonged period of time, they need to be imaged. Of course, recent head trauma. In little kids, remember, you may be the first to diagnose like neurofibromatosis or what's the other one? You get those little ash leaf spots. Tuberous sclerosis, all the neurocutaneous disorders. The seizure, a non-febrile seizure, could be their presenting symptom. So remember, when you're examining these kids, pay close attention to their skin. See if you see any weird-looking lesions, because this could be, and again, you'll pick that up on the imaging, but remember the neurocutaneous disorders. This is often how these kids are diagnosed, is a presenting non-febrile seizure.
So people aren't imaging new onset, run of the mill, generalized, recurrent tonic-clonic syndrome, tonic-clonic.
I think recurrent is the issue. So I think what the recommendations would say is that for one generalized tonic-clonic seizure that wasn't status, you wouldn't necessarily image.
Yeah.
If you felt comfortable that actually started generalized, which is usually the issue. Mom and dad usually walk into the room with the seizure ongoing, is what normally happens, I think. So most of the time you don't get a really good history of how the seizure actually started. They're caught in the middle of it.
But even in the outpatient setting, they're saying you don't always worry about neuroimaging.
No, I think what we end up happening is we image them more often because we never feel comfortable
Right.
for sure that it wasn't focal to begin with. But if you have a good history of like mom saw the entire event and it was generalized from beginning to end and it was one event, no, I don't think you have to image those kids. EEG in everybody. In all non-febrile seizures need EEG. Ideally within 48 hours of their seizure event. If it's positive, great. It helps you in your diagnosis. If it's negative, does that mean that they're normal, never to have another seizure, not going to have epilepsy? No, it does not. So a negative EEG doesn't really help you. A positive EEG does. How do you decide who to treat? Kid comes in with a non-febrile seizure. They automatically get medicine. Automatically, doesn't matter. You don't need to ask too many questions. They need medicine anyway. Doesn't matter. Is that true? Remember, seizure does not equal epilepsy. Some kids will have a seizure, never succeed again, however weirdly that may sound. So first time kid with one seizure in kind of this generalized tonic-clonic range, you don't have to treat them. Okay? If you have any weird history to it, you could consider treat, or an abnormal, of course, abnormal imaging or an abnormal EEG, you can go ahead and treat. Normal EEG, normal imaging, generalized seizure, just let them be. See how things turn out over the next couple months to years. You don't necessarily have to treat them right away. So, all that being said, there are several, again, very difficult. It's coming, just give me 1 second. Okay, watch it. See if you can notice it. Oh, here it is. All right. Oh, there he is again. Okay. So it's like Moro, right?
Yeah, go ahead. Let's start.
So there's a Moro, but remember, when should kids outgrow Moro? How old? 4 to 6 months. This kid's like 9 months old. He should not be Moroing. These are infantile spasms. Infantile spasms do horribly. You don't want to miss these. So if Unfortunately,
Even though we're watching a video, we're still missing it.
unfortunately, it's these like really subtle things that do worse. These do really badly. These kids usually go on to do horribly. So, if mom is telling you he startles easily and he's an older kid, and you're watching him and he's doing something like this and he is outside the range of Moro, 4 to 6 months, you need to be concerned.
Moro is the whole, you go up to them,
Right.
you go boo,
Yeah,
and
yeah.
they
It's-
go flee.
right, yeah.
That's
So it's usually
more like
like
I'm just watching
right.
you and you're
it's usually like a no, but unfortunately kids startle easily, so you don't necessarily have to knock their crib for them to Moro, you know, like just a voice sometimes that they're not expecting will make them Moro. So within infantile spasms diagnosed early on usually happens in these really neurologically impaired kids anyway. The ones that we're going to pick up are kids who are actually developing kind of normally, and they're not losing, we'll see it as they're not losing their infantile reflexes, but it's actually these spasms that look like a Moro reflex. So they're kind of lasting outside
So
the
with like
window.
infantile spasms, would you see like maybe they're on the latter end of the bell curve for like growth?
Usually, and maybe not necessarily their weight and length, but usually there'll be something else developmentally going on. Yeah,
like eye
usually,
contact.
or just like they're not motor wise or fine motor wise. There'll be some developmental milestones that they aren't reaching usually, or they'll be regressing. Will be the other thing, because normally these kids also have other types of seizures going on. Oftentimes infantile spasms don't happen in isolation. We already talked about absence.
But we're doing, I'm sorry, so we're doing entire workup like for regular seizure, seeing this kind of spasm?
Yeah. So it becomes a little bit, and again, remember, most of the time these kids, especially in these harder to pick up seizures, these kids are often not going to be stone cold normal otherwise. So these seizures that do horribly, if you're seeing them over time, because you're like listening to mom's concerns, you're going to see some regression in developmental milestones. There's going to be some other episodes going on that are just weird, like things shouldn't, in most cases, be adding up to just this normal kid or normal baby. Like there will be other stuff going on, because these seizures usually indicate a neurologic impairment that's going to present itself in other ways, if that makes sense. Most of the seizures that go on to do okay, they'll develop otherwise normally, but the like infantile spasms, Lennox-Gastaut syndrome, some of these that don't do well, you'll see developmental trouble in these children.
And sometimes, don't forget, you don't have to necessarily refer everybody to Pete's Neuro, but a phone call to Pete's
Right.
Neuro can be very helpful with something like this. And they'll, at least in Denver, they'll talk to you they'll tell you exactly what to do, you know, and you're like, I don't know, this is a kid's seizure, what do I know about this? They'll really be helpful.
So absent seizures, I already showed you all those videos on. This one becomes difficult because like it's the typical ADHD kid of like I call his name and he won't respond to me. Like he answers me when he feels like it, kind of thing. You know, it's these staring episodes. The one thing that can help is do y'all know how to precipitate absent seizures? You can make these kids seize.
Strobe lights?
Nope. Hyperventilate. So you hold a Kleenex in front of them and tell them to like blow on it and make it move as fast as they can. And if you hyperventilate them, they will all of a sudden stop and go into an absent seizure. So if you have a suspicion that that's what's going on, then you can try and precipitate one in the office and see.
Only if they have the diagnosis. I mean, if they do have abscess, you're not just any kid, right?
Yeah. If mom,
It doesn't
if this is coming, because again, the history. I mean, all these are, and these can actually be like these can be 2 or 3 seconds in length. So if like they can just be working and all of a sudden just kind of, and then go back to working. Like that may be all you get. So if you're trying to figure out if this is just an inattentive kid versus an absent seizure, you can try and precipitate one in the office by hyperventilating them. Benign Rolandic epilepsy. So these kids have, shoot, the wrong clip in there. It's a form of epilepsy. These are really common in kids. These kids usually how it's diagnosed is mom and dad will catch them in a generalized tonic-clonic seizure at night. But these kids actually do really well. But they have complex partial and generalized tonic-clonic seizures. But they do well on the long haul. This is one of the very few variants of epilepsy where there's two types of seizures involved where the kid does good in the long run. Most of the time, if you get the history of two different types of seizure activity, that usually equates to badness. Okay, so if they're telling you my kid has generalized tonic-clonic seizures or my kid has these like atonic drops or myoclonic jerks, if they're having all of those different types, that usually equates to not goodness, not anything good at all. And that's what these kids are, these Lennox-Gastaut syndrome kids. So the clip I showed you of the girl, that's what she has. She has Lennox-Gastaut. They usually have 3 or 4 different types of seizure activity, and they go on to do horribly. Most of their seizure type, though, is not generalized tonic-clonic. They'll have absent seizures, they'll have these little staring episodes, they'll have these complex partial picking episodes, they'll have little myoclonic jerk episodes, but they seize all the time. Like they seize they'll seize hundreds of times a day, but it'll just be these little episodes. But over the arc of the day, they have just as much seizure burden on their brain as someone who's doing this horrible looking generalized tonic-clonic seizure. So these are the kids that wear the helmets because they have the myoclonic jerks that just make them fall on the floor and hit their head all the time. So these kids do not do well. I actually have a patient with this. Brianna and I saw her one time. These kids get diagnosed in adolescence. And I don't remember what video I put on here. Oh, they usually get diagnosed in adolescence, but this is kind of what happens. So mom posted this because she did not know what was going on with her kids. And she couldn't explain it to a doctor, so she just videotaped him doing it. And here's his siblings laughing at him. He can't.
That is a cute kid.
But they just have these jerks. So my patient, she was in adolescence when hers started. Those are myoclonic seizures. Usually what happens is like she would just like all of a sudden fall, or she'd be trying to eat and like she'd be lifting the fork up and she'd just fling her food off. So they have these myoclonic jerks that can affect their postural tone or can just affect an extremity. It usually happens in adolescence, and it's usually precipitated by lack of sleep or anxiety and stress, which lots of teenagers have both of. So it tends to happen a lot in teenagers. These people do really well though.
How do you differentiate the myoclonic from the partial simple?
So partial simple is usually actual like seizure activity, like what you saw with that kid. You know, it was kind of prolonged, which you would imagine being a generalized tonic-clonic thing. You know, it's more prolonged. Myoclonic jerks are really just that. They're just these like jerks,
Just
and
the
it's over.
extremity?
Yeah, usually. Sometimes it can affect the legs though and make them fall down. It can also affect their head. So you'll just have these kids with these head bobs. Your head will just fall, and it just falls, and then they're over it. So it can affect kind of any extremity, but it's like 1 second and it's done with. Oh shoot! Sorry guys. Okay. Status we already talked about. We already talked about management. So the other thing is just related to medications. Knowing when to start medications and which ones to stop. Really, when it comes to this, we often choose the second generation list because these don't have to be followed with levels and usually have less side effects. When it comes to which one to pick, you usually just pick. The exception to that is absent seizures respond best to ethosuximine, and you don't want to use Tegretol. Otherwise, you kind of just pick medicine and see how they do. Overall, most kids with seizures are going to do great. You'll kind of know within your first year of treatment how they're going to do. Most people, the majority of kids are going to go into remission. If you don't get them into remission in the first year with your medications, those are the kids that you're probably going to struggle with and would want to get neuro involved if you haven't already. Those are the kids that are going to be least likely to go into remission or that you're going to be able to get control of their seizure activity. So, remember seizure mimics in kids and babies. Your most common seizure mimic is breath holding spells, which can look completely like seizures. The key question to ask is, were they screaming and pitching a fit right before it happened? Because what will happen is they will scream, and like they will continue to forcefully exhale until they go blue and pass out. And when they pass out, they will have what looks like seizure activity. See how he's not breathing? It will just stop he'll just stop and kind of go limp.
That's scarier looking.
And then all of a sudden, they'll remember and he'll breathe and then it's over. But some kids will pass out when this happens. And again, looks terrifying to mom and dad. But it's normally because they're so angry that they forget to breathe. All kids grow out of this. It's not dangerous. But,
What ages do they do that?
He's like, what's up?
this can actually go into early childhood, but usually happens in like kind of that infancy into toddler age. So remember breath holding spells in your differential, and when they get into teenagers, remember psychogenic seizures. The crazy girls who like have the seizure activity but can talk to you. So remember conversion disorder and psychogenic seizures when you're thinking about this. You don't see this in childhood, but you'll see it in adolescence. In childhood, your main differential is going to be breath holding spells, because those kids definitely don't need to be treated with antiepileptics. So, okay. Sorry, I'm running late. Sorry.
Can you put this on our Google Drive?
Yes, for sure.
So we can see this treatments and stuff.
Okay. My fault. Sorry. Okay. Back to work.
That's scary.
My next one.